Tonight we're going to talk about how to approach a new oncology patient. I'm really going to focus on just the care for them for the first 12 hours. So one of the critical things that can really become a problem over the long term is communication errors. These are people who have recently, as in a few minutes ago, found that their child has a life-threatening illness. They're absolutely terrified, and they are not going to be in their worst condition. And this goes for interpersonal relationships. If mom and dad have a rocky divorce, it's not going to get smoother now that their child has leukemia. So you're going to have to sort of adapt to that and do things in terms of communicating with these people that you may not have normally to do. One of the critical things to remember is calm, straightforward communications given in small, direct bits. Keep it concrete and keep it focused on the near term, like what we're going to do now, what we're going to do in a couple of hours, what we're going to do tomorrow. Don't worry about the long-term stuff. Leave that to the attending. It's also important that we keep one voice from the treatment team to the family, particularly in the case of broken families or families that seem particularly disrupted. It's important to have one person do the talking. So cancer comes associated with other things, and many of the coexisting conditions that you'll see on admission include fever, fatigue, bleeding, pain, and then three that are particularly scary and warrant PICU consultation or admission: any form of airway compromise, any kind of spinal cord compression, or renal dysfunction. It's also important to remember the fever can occur because of the tumor itself or because of infection. Bleeding can occur because of low platelets, given that the marrow is replaced by leukemia cells, or it can be caused from DIC or other coagulopathies. And so it's important to remember that you need to do more evaluation for these symptoms. Some signs of sepsis. These are important because when you have a new leukemic, for example, the total white blood cell count may be very high, but the number of actual functioning white blood cells can be remarkably small. And so things to watch for: fever or hypothermia, altered mental status, sleepiness, difficult to arouse, and so on. Tachycardia or wide pulse pressure, or septic emboli. And you'll recognize these as sort of a hematoma-looking thing that you'll be able to palpate and either see a pustule in the middle of or see some necrotic tissue in the middle of. And those are warning signs of bacteremia or sepsis. Airway compromise comes in two forms in cancer patients. One is the obstruction of the upper airway in the neck, and the other is compression of the lower airway inside the chest. In the neck, this often occurs with retropharyngeal sarcomas or lymphomas that grow around the airway or grow behind it and squeeze it forward. In the chest, this commonly is associated with mediastinal adenopathy that squeezes the trachea between the sternum and the mass, or between the mass and another node. The way to approach these patients is to allow them to find positions of comfort, give them oxygen if needed, and then emergently transfer them to the PICU where they can be monitored and where airway intervention can be done quickly. The hematology oncology attending on call should be called right away. Tumor lysis syndrome is another common issue. Tumor lysis syndrome results from the excessive breakdown of cells and releasing their DNA and other cell products. The DNA breaks down into purine and pyrimidines. The purines turn into uric acid. The DNA also has a large amount of phosphate and a large amount of potassium. These result in combined attack on the kidney and the heart. Uric acid and phosphate form crystals in the tubules and will impact on renal function, resulting in renal failure. This results in a sudden spike in potassium levels that can affect the heart and cause cardiac arrhythmia. So, starting your admission orders, first is to calculate body surface area. The body surface area is really simple. It's the square root of the product of the height in centimeters multiplied by the weight in kilos divided by 3,600. This will give you a good two-digit estimate of body surface area. Body surface area is important in cancer because all fluid orders and all chemo doses are based on body surface area rather than weight. So some basic tests to order: CBC, coags, and chemistries. You want to make sure you have a clear idea of what the rest of the marrow is functioning like in a leukemia, or you want to know whether the patient's anemic and needs emergent transfusion. So CBC is going to help you there. PT and PTT, or else even an entire DIC screen looking for evidence of coagulopathy or liver dysfunction. A CMET is going to help you find electrolyte issues such as tumor lysis syndrome. It's going to help you find liver dysfunction and bilirubin issues, which will affect chemotherapy drug administration. LDH can be as a marker of cell turnover, and several tumors are prognostically affected by the amount of LDH present at diagnosis. Examples of these include neuroblastoma, Ewing sarcoma, and osteosarcoma. Then you want to send a type and a possible at the university or specimen to blood bank for possible transfusion to Children's, because you want to make sure that you get that transfusion started as soon as you need it. And you're going to need a blood transfusion probably sometime within the first 72 hours, either because they're anemic or because they're going to have surgery, and they might as well get that specimen cooking. Another thing to remember to add to your basic admission orders is viral titers. These vary in terms of importance or necessity depending on what tumor you have, but all patients are going to need a CMV titer because CMV status is going to affect transfusions. All patients are going to need varicella titers because chickenpox exposures still occur despite vaccinations, and having some sense of whether they're immune or not helps modify treatment plans in the case of an exposure. Lymphoma patients will frequently need EBV titers, HIV titers. Bone marrow transplant patients certainly need HSV 1 and 2 titers, and all of these can be drawn at admission. PCR studies for some viruses can be added depending on the tumor you suspect. So tumor lysis syndrome can be prevented, and it can be ameliorated if it's started to occur. We start with IV hydration with D5 and 1/2 normal or D5 and normal saline at 2 times maintenance. This is 125 milliliters per meter squared per hour. Do not add potassium or other potassium sources to the IV fluid. Do not use lactated ringers or other premixed balanced salt solutions that contain potassium. You want to start trying to break down uric acid or prevent its formation. If you have a low uric acid level to start with and you're planning on chemotherapy more than 24 hours from admission, start with allopurinol. Allopurinol is an oral drug. It's easy to give, it's inexpensive, and it works very well in a standard risk patient. The dose is 10 milligrams per kilogram per day, divided twice or 3 times a day. A common trick is to give an entire day's dose on the first a day of hospitalization so that you get a large amount in. In a person who has a high risk, such as a person who already shows evidence of tumor lysis or has a very high uric acid at admission or persons who can't swallow medication because of some reason, this drug is used. 0.2 milligrams per kilogram per day intravenously. It is much more expensive than allopurinol, and so it's held just for the high-risk patient. A few standard consults are always added, and these are the psychosocial team. And this is really an important area to concentrate on. You want to make sure the social worker is consulted, education support, child life, psychology, the nurse coordinator, and nutrition. Family may or may not want a pastor or clergy member to see them, and they may have their own. And certainly you would add a clergyman or a hospital chaplain to this if they wanted one but didn't have their own, or were from out of town and had to rely on a local clergy member. The real indication for these is that cancer is an expensive disease. There's all sorts of little mines in the field that have to be navigated around, and these folks are able to do that. Additionally, they're very stressful diseases, and many of the mental health workers we have are good with children, but identify the child as the identified patient rather than parents. And so having that social worker or having that nurse as an outlet for the parents helps them voice concerns that they may have not been able to voice to the treatment team, or having them bring up their own emotional needs so we can deal with them. So if you're thinking about a new admission in the middle of the night, who do you call? Of course, you call the hematology oncology attending on call straight away. Next, you want to think about the surgical consultants you may need. Does this person have a abdominal tumor? Does this person have airway compromise? Does this person have spinal cord compromise? You want to look for OR scheduling. A leukemic's going to need a bone marrow and a spinal tap. You may want to give OR desk a call and find out what time slots they have available. Not that you're going to schedule it, but you're going to help out your attending by telling them that they have 3 slots available, and here are the 3 times available, and you can pick one. You want to transfer to the PICU if any of these abnormalities are found. An elevated white blood cell count, certainly over 100,000. In AML and CML, tumors which are known to be more adhesive, even a case over 50,000, white blood cell count over 50,000 may well be an indication for a PICU admission, at least overnight. And then medical students don't get much pediatric training. They only get a handful of exposure days in the inpatient unit, and you're going to make sure they take all advantages of everything they can see. So make this medical student you have go see the patient, make them go look at the labs, make them go look at the x-rays, make them go look at the blood smears. Take advantage of this because these are not common diseases, and if you don't take advantage of them, they won't have that learning opportunity, and we won't produce the good medical students we want to produce. So thanks for your attention. If you have any questions, drop me an email. Bye-bye.